healthcare providers to continually learn. And if we have residents also, they're going to challenge us to always be on the cutting edge of medicine and to understand what the latest, newest practices are so we can bring that to the community.
I appreciate your answer, Dr. Jumpinico, but that plan of action was for Mr. Raw. What is your plan for accountability when there's a concern within our IHS facility?
As the acting area director, I am accountable for all the successes and the errors and the mistakes. We follow up on every grievance. We follow up on every hotline complaint. We do root cause analysis on issues that we have that we experience within all of our facilities and come up with policies and procedures and ways to avoid the recurrence of those bad outcomes.
One thing I want to add is in direct response to some of the things you're bringing out at the area level, we recently created a quality department and a director of quality and compliance and risk management to try to make us better at learning from mistakes that have happened in the past and putting in the policies and procedures that allow us to avoid making those mistakes again. So I think that that's been an important step. You're touching on a lot of the things that we agree are really important. Having rigorous credentialing and privileging processes so that you bring the right people with the right set of skills to this area. Honestly, working in this environment is much more difficult than working in environments that have bigger hospital centers and specialists at their right hand. So I think we find, if anything, that we need to be even more rigorous about bringing in people with a wide range of skill sets because we see such a high level of complexity and we don't have the specialists at our disposal like we would in a bigger city. So credentialing and privileging has been a huge focus of ours, as is, like you said, the quality issues. And none of us on this panel ever want to see that happen to anybody. And I think we do very much take it personally and want to make sure that to the extent that we are able, we can put measures in place, put system solutions in place so that those things don't happen again. And I don't want to discount the academic partnerships. I think is a very exciting thing for us because it really has the potential to bring trainees that have interest in rural medicine and hopefully will stay in their early careers here and help us to just continuously build on successes. So I really think that all of us are very excited by those opportunities, and Dr. Jumbinho has put a lot of work into. I think we are beginning to see the results of that.
And I just wanted to briefly mention, as Captain Rolfs mentioned earlier, he mentioned that the CCRT team is currently at the Pine Ridge Hospital. And that has been, the acronym is the Critical Care Response Team. And as you know, being rural, it's very hard for us to get out to attend education seminars and conferences. We're farther away than many people where those are held. A lot of times we have to go to big cities to attend those things. So we have different challenges around that in keeping our staff educated and bringing the most cutting edge things. And we were able to work with headquarters and explain that as a challenge to our chief medical officer and our leadership. And so together they came up with a potential solution during COVID, because all across the country as healthcare professionals, we all needed to learn about COVID. And so we don't have an intensive care unit. We don't have that level of specialty. But because all of our referring hospitals that we transfer people out to were so full, we really had to learn more, be better competencied, understand how we could care people for longer before we could get them transferred to a higher level of care. And so we have, in the past 3 weeks, had a doctor that specializes in intensive care, respiratory therapist, and 2 specially certified critical care nurses working with our inpatient and ER and outpatient staff, teaching them not only COVID, but also higher skill levels that over time have gone away from some of our rural healthcare settings. And so we're practicing those skills, and we're getting hands-on demos and practice and repeat and learning right there at the hospital by experts. So the team was brought to us instead of us having to send everybody out. And I think that that has been one very beneficial program that I think all of us have learned a lot from, of what we can do in a rural setting to bring those types of trainings to us instead of always looking to the outside.
Thank you for hitting on mobile training teams, because that was going to be another question for Mr. Roth, was the opportunity to bring mobile training teams here with us being rural. My second question is housing, and is it the lack of housing that is the reason for the lack of staff being brought here?
I'll let Dr. Jumping Eagle, she communicates more with the applicants, but I think it is. It contributes to that. For instance, I think we only have 5 quarters units at Wombly, and so a majority of those staff are commuting sometimes if they're not local from Wall, and of course we have, what's that? Or Kadoka. So it's taxing on them over and over. It gets worse in the winter time on tough roads, but you know, they're dedicated employees. So I do think it contributes to that, but there's many other factors. I suppose Dr. Jumping Eagle can elaborate a little more.
We do have, you know, some situations, or especially, you know, the different types of schedules. We have different types of schedules that we can work with employees on, but it's not as flexible as, for example, in private settings. So that sometimes is a limitation. We try to work with people as much as we can, especially depending on what the clinic schedule is, for example. Seems to be challenging. We've also had some situations, for example, we had been trying to recruit a psychiatrist for quite a long time, and we changed that position to a telepsychiatrist, and then I had a lot of applicants for that. So we have a telepsychiatrist that will be starting soon. So I think, you know, there are challenges where maybe people don't necessarily want to, you know, they may have a whole family, you know, going to school or whatever, and they're not necessarily going to entirely move here, but they want to do something where they're going to do part-time here and there. So that's where we have to be as flexible as we can to work with them and take into housing as a factor as well. So those are some of the challenges that we run into. And then we try to be as competitive as we can with the salary offers. It has definitely helped with the recent increase in the nursing salaries, but that has been a challenge sometimes.
Thank you. And my last question is for Mr. Amiot. Mr. Amiot, recently I reached out to our chief of staff trying to find a paper trail regarding 2 homes that were built by Habitat for Humanity and placed on the IHS campus. They were vacant, 2 vacant homes up until very recently. And in our HHS committee meeting, we took action to give those homes to our CPS program, as there was no housing facility for our displaced children as they were transitioning from one home to another home. As it is right now, they do currently house them in a CPS building that doesn't provide adequate, in my opinion, doesn't provide adequate bedding, an adequate kitchen, or just give them some sort of comfort in between their transition from one traumatic scenario to possibly another traumatic scenario. And my understanding where those homes were built for our women's shelter, but because there was a grant didn't get approved, they were left vacant. But then recently they were filled by 2 families. So I've asked for the deeds and when those were given to IHS. and I was told that you would be the person to speak with. And the chief of staff said she reached out, but I never got a follow-up answer.
Yeah, I think it was in December. Chief of Staff Janice and Chuck Ross both reached out to me asking for the documentation. And what I found is a letter from Habitat Humanity transferring over ownership of those from them to IHS. And the letter does mention for baby or health uses. So, and I believe the house is now on our inventory list. So I did respond back to Chuck and Terry and read them the letter. And they did ask for a copy. So I inquired in our processes, am I able to share that letter? And was told that it would need to be a FOIA request. So I took those requests from Chuck and Terry as an informal FOIA request. And so we can send that on to our FOIA person at headquarters. And then I can release those letters once that happens. But the letter was CC'd to the tribe also, so I don't know if your guys' archives have those too, but I think it was 2019, maybe 20. Do you know the date of that letter? (2017), I believe.
Okay, thank you. Thank you, Chair.
All right, thank you. I got Vice Chair Yellowboy, and then Councilman Dreamer, and then Councilman Ironclad.
Thank you, Mr. Chair. Good afternoon to our guests. I didn't catch your name. I was late this morning. I was dealing with another issue with our housing. So I do apologize if I don't know your name. And good afternoon, Dr. Jumping Eagle. So being here today and on my way out, I received several calls and texts, and you've probably seen me leaving in and out, taking those calls or answering. And they're all good questions that the people are asking. And so I'm going to try and decipher as much questions as they want me to ask in a short amount of time. So my first question is, and this is probably for Ms. Knutson up there, is when it comes to patient care for nursing staff, and my colleague over there had asked or had made a statement that there is no patient ratio to the nursing staff. When is it a concern when the nursing staff is more than the patient load? When do you see that as a problem? Because, and I'm going to tell you a situation here where I myself had to clean my sister's wounds because they were so busy and the patient load was so high. And there's times where she was in there and she cleaned her own wound and was given her all the supplies and put in a room and said, sorry, clean, we're busy, we have to tend this over here. So to me, that's not right. A patient should not be cleaning their own wound.
I agree with you. And I would like some specific information after this meeting related to that incident, as this is the first I'm hearing of it. Our patients that have wounds and that are in the hospital for wounds, there are specific orders and requirements that occur during that hospital stay, which do require nursing's assessment of those wounds. So if that is not occurring, that is a violation of a standard of care, and that's an immediate concern to me. As far as patient-staff ratios, nurse-to-patient ratios, this has been debated across the country by nursing through the American Nurses Association for many years. And there, to date, has not been a solid nurse-to-patient ratio. And part of that is related to exactly what Ms. Carlo brought up earlier with the acuity. And so that nurse-to-patient ratio depends on that patient's acuity level and how many of those we have on inpatient at that time. And then we change our staffing to try to meet those. And sometimes it requires more nurses. Sometimes it requires more unlicensed assistive personnel, such as health techs or MSAs. So the situation can vary differently, but providing standard of care practice is of an immediate concern to us always with our patients.
And upon being in her room and finishing cleaning the wound that was on her leg and wrapping it, another nurse came in and brought her, and when I went in there, I didn't identify myself as a council representative. I went in, I sat down in her room, and I was sitting there, and I don't know if it was because of somebody knew who I was, but they brought her a CMS number, brought her several pieces of paper, and told her to write everything up and submit it to CMS. So your nurses are the ones up there telling the patients, which I applaud them, because this should not be happening in our own healthcare system. You know, we talk about healthcare, and you guys are making it sound like it's hunky-dory. I see it as a third world system. This isn't a hospital, this is triage. And when I say that, my next question is, when you bring in your contractors for the ED department, somebody needs to go through with them and tell them not to be rude to those patients. That is another concern that I'm getting. That the contractors, the ambulance contractors, there was a thing on Facebook, somebody showed a video of the ambulance personnel getting rough, your contracted ambulance personnel getting rough with a patient on a stretcher. You know, these are concerns that are being brought up. And, you know, I try my best to disseminate that information and trying to point them in the right direction. But I'm glad you're here today, because now you're hearing from each and every one of us. And there's some things that, you know, we want answers to, and Dr. Jumping Eagle tries to do as best as she can to answer them. But I'm glad you two, you three, you four, you five that are here to hear these questions, even though they ain't gonna mean nothing to you after you leave. Because this is the same song and dance we get. We come, we sit, we tell you our problems, and there's no resolve to them. And I was sitting here and I was thinking to myself, do I be nice or do I actually tell what people feel? And this is how people are feeling out there. We're frustrated. We get onto the third-party billing. I have college students that are out to college getting bills because IHS is refusing to pay them. We have a colleague on our council here that was referred by IHS and is getting billed. I'm afraid to get a referral. I know I went up for my appointment 3 weeks ago, and my doctor said, I'll put in a referral for you. At this point, I'm scared to get a referral because I'm going to be in charge of that bill afterwards. We're damaging our tribal members' credit, and it's not even us that's doing it. It's them trying to go to the hospital to get the basic health care they need. My next question is, we talk about lack of staffing. Do you keep a statistic of how much employees you recruited and how much employees you lost in our Great Plains area? And is that percentage greater or less than recruiting? And what was the reason why of moving your HR departments from each service unit to area office?
During the pandemic, we have seen more attrition than hires. I don't know, we keep the statistics and it's a running total, it's HR. I don't have that information at my fingertips. I could provide it, but it's pretty universal throughout all the service units, and Pine Ridge is certainly a victim of us being shorter staffed now than what we were 2 years ago. It's not a lack of effort, and it's certainly not a lack of passion on our part to try to make things and improve things and to address these stories and these incidences that we feel for and that we commit our careers to making better. So I understand your passion. I appreciate that passion. We share that. This team that you see here before you today, I have never worked with a more passionate group, any of them, with what they do and how they approach their jobs and their focus and their commitment to our patients. So just so I want that clear, whether you can feel that or not, I wish you could feel it more, but I appreciate your frustration and your passion. Across the country right now, there is a critical shortage of healthcare. People are leaving, people are retiring, and people are choosing different careers in our colleges. And it's a big issue.
I would say, this is Dr. Jumping Eagle, for the service unit, we do track our vacancy rates for all of our positions. We're at a 34% vacancy rate, but that's been, from my memory, fairly consistent. So although we have had staff who have, some who've retired or we're going through some transitions, we have had other staff that we have been able to recruit. And that's in the reports that you receive from me on a monthly basis. That's some of the data that you receive as tribal council. Regarding your concerns about the emergency department and the ambulance, for me as the CEO, it's most helpful if, especially for you listeners, if you have a concern about, the care that you're receiving, I encourage you, if something's occurring in real time, when you're in the hospital or receiving that care, you can ask for the patient advocate, you can ask for the hospital liaison, you can also ask for the CEO or the deputy CEO. And we're always responding to, anything we can try to help resolve as it's happening. And if that isn't comfortable for you, and if one of you as OST council persons receives a concern, the closer to real time that we receive that concern, that's helpful, including dates and times so that we can go back and address the specific contractor or employee. And this is, does somebody need help with retraining? Does somebody need customer service? Does somebody, another item that we've implemented with our team is more, we've always had cultural, relevancy training that we've implemented as part of our employee orientation process, but we could do that again if we have to do that, or if it comes to the point where we have to inform a contract company that we want specific people removed because they're not providing the customer care that we want for our community members, then that's what we'll do. But we have to follow up to specific issues. And it helps if somebody tells me something and I can put it in writing myself. But to receive general things, maybe a month or two later, and all of you here on the council have my phone number, and you've called me at different times about different issues. So if you could call me when you receive these concerns so I can follow up on them, I would appreciate that. Regarding, and I don't know if you were here earlier, Councilman Yellowboy, regarding when we talked about PRC, but we are following up with our PRC department regarding performance improvement as much as we can do within our program, but we're also following up with the area to look at the company that we send our purchase orders to and their turnaround time. So we're bringing that up with the area and headquarters as well. And that was part of an earlier discussion that we had. So we will not tolerate people getting rough with our patients or unprofessional behavior. So if after this, if you could give more details about that one-on-one, that would be appreciated.
Thank you. As you were talking, I had about 9 text messages come in stating that they've reported and nothing's been done, so. And my question of the HR wasn't answered either, but I guess I'll move on to my next
I
question.
would say for the
So my-
HR process, I could
that's
answer
fine.
that.
That's fine.
I could answer that question.
That's fine. No, I was asking the area director, but that's fine. So my next question is, when it comes to the budgets in our area, you just talked about adding on another position or adding on another committee. What is the total budget that area receives for the Great Plains area? What is the total amount of funding do we receive in our area?
I don't have that number in front of me. I wasn't prepared to report on that today. We can get it and we can provide that.
I'm only asking that because that leads up to my next question is, what is the funding that the Pioneer Service Unit receives out of that? And is that new department or new person you just put on or new committee, is that taking away from funding from our service unit?
No, there is no funding that's taking away from the service units. Some of the staffing package with the inflationary increases that you've received since 1993 are set and established. Some of the funding comes down or through user pop based on a proportionate share, but none of it's taken away from the service unit for any other service unit or area functions. That's just not how the funding comes down, and that's not how the funding gets distributed. There's actually funds available funds out there that we make special requests and have been since 2018, whenever the accreditation issues took, some lost revenue types and accreditation funds, that we make special requests to make sure that Pine Ridge does have the full gamut of services provided.
So I'd like to see what we receive. That's something that I want to see, because from my point of view, we're getting peanuts. That's what it comes down to.
That's very available information. We just had the governing body meeting yesterday. There's a financial report that covers all of those pots of money that we talked about before, what comes in, and that budget. It's in the open session, very much available to your leadership.
Thank you.
Thank you, Vice Chairman. Councilman Dreamer.
Thank you, Chair. This is in regards to the vaccines. This happened today. An individual went up there to get his vaccine, and he was going to take the Johnson & Johnson, but the nurse at the time told him that it's been, studies been showing that it's been causing blood clots. So if that's the case and that's the study, why are we still having Johnson & Johnson on our shelves and giving to our people?
So we offer the full vaccines that are available from the CDC for individuals to have a choice. The Johnson & Johnson vaccine last fall, early fall, late summer, was shown in certain age and gender individuals to have an increased cause of blood clots, usually females of a middle to older age. But part of our responsibility as vaccinators, we do have to make the public aware of any potential side effects. We have pre-screening questions that we ask every individual prior to getting a vaccine in order to make sure that we cover those issues that have been brought forward, so that they can make the best informed choice of the vaccine that they like. And many people do choose the Johnson & Johnson because it's one and done, where the other vaccine choices out there are multiple dose series. And so for some people, that is their preference.
Thank you.
Thank you, Councilman. Councilman Ironclad, and then Councilman Youngman.
My question is for Mr. Bershiel. There's several of us sitting in this circle here that are descendants of the 1868 treaty, and I guess that was one of the first treaties where healthcare was put into the treaty. And the person sitting next to me is Mr. Youngman, but his grandfather was the first signer of the 1868 treaty, and my grandfather was the third signer of the 1868 treaty. And there's another councilman here named Austin Watkins, whose grandfather was Chief American Horse. He's the seventh signer of the 1868 treaty. And there are several here that are descendants of Chief Red Cloud, who are also, the descendants of he was the last signer of the 1868 treaty, which was in 1868. And I guess the question I have was, Rosebud recently won a significant treaty case in regard to healthcare. Could you tell us a little bit about that?
I have to put on my former tribal leader hat currently. My name is William Bearshiel. Everybody calls me Willie. I've worked with several of you over the years. And this was one of the issues that we had worked on, was what does that treaty mean? What does healthcare mean? And I told the tribes when I worked for them at the time, I think the tribes need to define that. They need to say that includes competent health care, whether it's a physician, a hospital, what have you. Just like it mentions a teacher and school in there. So in the end, prior to coming to Indian Health Service, we talked. I had spent several terms at Rosebud. I was on the health board every term. We had issues with everything that you've talked about here today, from CHISDA to, once again, not enough money. I took it upon myself to go another level, and from being the chairman of the Unified Health Board, which consisted of individuals from here, sitting here today, from Pine Ridge, Cheyenne River, Rosebud, and Crow Creek. And the day the resolution was passed, we had all 4 chairmen of all tribes in our council chambers. And I don't know when the last time that was probably ever done, but in the end, we decided, we were working with Robbins and Kaplan at the time, and they thought that rather than all tribes get together, it would be better for them just to go it alone with one tribe. But it was for all signers of that treaty. A final appeal, I think, was dropped just a month or 2 ago. And what does that mean to the tribes? I think that means a turning point in healthcare, Indian healthcare. I feel the tribes need to get together, maybe with their attorneys. I know Ms. Hughes is listening. I've worked with Ms. Hughes. I've worked with Mr. Mulholland, and see what that means, budget-wise. I feel that's the answer to a lot of the questions that we talked about here today. And I told Mr. Poirier, maybe that PRC budget needs to be a thing of the past. Maybe we can ask Congress as tribal constituents, leaders, everybody involved in tribal health care, ask Congress for those dollars. I don't think it would hurt. See what they say, that treaty is a contract between Congress and the tribes that it represents. And I've always harped when I was a tribal leader that, we take a little more responsibility in our own health care. I think we're at that point. Whether it happens 10 years or 20 years from now, I think we could at least say, hey, we were all together on a turning point. There's several turning points. There's several good things that have gone on, that have happened in Great Plains healthcare. The reassumption, that's the way I call it, of the clinic in Rapid City. The individuals that sit here that know that we always wanted to have a specialty care hospital for Indian Health Service. So that PRC budget can be a thing of the past. We can pay the doctors to come to have their own specialty services there with high-paid doctors that are equivalent to those that come to Monument or Sanford or Avera. And the model plan come from Dr. Don Warren, who is a tribal member here. The Unified Health Board at our tribal council, I had him come. I had him give us that vision of Indian healthcare. I think we're at that turning point now, sir. I really think we get involved and work together. I think that is what tribal health should look like. Those are my opinions as a tribal member from Rosebud, and as someone like all of us, everybody here, that cares about healthcare. Thank you.
Thank you very much.
Thank you, Councilman. So we got Councilman Youngman, Councilman Poirier, and Councilman Dillon.
I just got a few things from a couple of people just wrote for Ms. Jumping Eagle. They wanted to know about adding people to pick up meds. What's the process on that?
I don't know actually the specific process, but there is a process to have a designee to pick up medications. If it's specifically for controlled substances, they have to show an ID. But I can get a hold the information from pharmacy, and then I could send it to tribal council. The other thing we could do is I could talk to them about doing a PSA, and we could put that on our Facebook page too.
Okay, thank you. The other thing is, we're still getting complaints about, customer service. I see you guys have signs up there that says, if a patient gets mad or starts cussing around, you guys will call the cops on them or do whatever, but it has to work both ways, where a patient's getting treated badly up there too. They need to be held accountable. And I know you brought up that he was doing some type of customer service training or something like that. I think that needs to be looked into.
Yes, we are working with our staff. We do reminders, just reminding our staff that, we have a lot of challenges in our community where people have difficulty getting rides. We want our staff to be flexible if somebody's late to their appointment, or if they need help navigating the system. Sometimes it's hard for people to, for example, know that they have to check in at registration before they go to the clinic desk, and people get annoyed by some of those processes. So we do have our patient advocate and our hospital liaison who can help with those things, but we just remind all of our staff that we all should be helping people to navigate how to get to their appointments. Another big push we've had is for the phone systems. That's a lot of complaints that we get, is that people aren't answering the phones, or they kind of get transferred around. I call it the circle of pain. And so I talk to our different departments, for example, pharmacy, that if someone's calling there, that the expectation that is somebody answers the phone by the third ring, those types of things. And we're talking to outpatient about that as well. So, but please continue to give us feedback on ways that we can improve. We're also talking about our hospital liaison mentioned that the VA does like text reminders. I'm asking pharmacy if we could look into how we could implement that process. We had a complaint about trying to get refills. So how could we, if somebody's working on getting their refill processed, how could we let people know their refill's ready if they have text available? Things like that would be more customer friendly.
And I think the biggest frustration, and listening to some of the ones who've been on council for some years, there's never been any significant change. So, when I was sitting here listening to our last meetings, even at the beginning of our term, I thought you guys were smudging over there because there's a bunch of smoke coming up, because it's kind of the same smoke screen that we get all the time. But, I would really love to do a partnership or something if you can show us change, because right now it's been the same old story. I mean, even as a kid growing up, and I know it comes a lot to funding, but there's things that we can do. And if not, maybe IHS isn't our way to go. I've met with tribes that have the Title V, I think it's Title V or Title IV, one of them, that did that, and it's worked for them. So maybe that's something else we need to think about too. Oh, thank you.
So I would really welcome that, sir, to have you come to IHS and see all the good things that are happening, to see the good care, to see the changes. Sometimes, as Councilman was mentioned earlier, we work for IHS, so some of that history and that burden is carried with us and is on us. But that doesn't change all the good work that happens every day. It doesn't change the accomplishments that we have every day. So I've heard some things here where we're here in front of you to take your questions and ask to work together. But at some point, we're not even allowed the opportunity to respond. It's like we're just being talked at. This isn't necessarily the forum for that conversation and a back and forth, and for us to be able to reciprocate what the honest truth is. And so I really invite you to come so we can have that true conversation about what's going on there. So you can see all that Dr. Jumping has done in the last year and a half at Pine Ridge. I'm currently the acting CEO at the Cheyenne River Health Center in Eagle Butte the last 2 months. And so every day I've heard it said that once we leave here, we don't care. And I think there's nothing more untrue than that. Because when I'm sitting in Eagle Butte at 9 o'clock at night trying to finish the day's work, Dr. Jumping Eagle's texting me or emailing me saying, hey, I need this signed. Because she's also sitting in that office. And then gets up first thing in the morning and does it again every day for years and years, after having gone to school to be a doctor. So there's nothing more untrue and nothing more unfair than to say we don't care. And we do support 638. If that's the way the tribe wants to go, Title I, Title V, 100% support from everyone here. But when you do, the people that you're going to ask to fill those positions are the ones that you're saying now leave here and don't care. So that is our own tribal members. So I just want you to come and we'll have a meeting at the hospital and we'll have a presentation to show all the good things. So that it's not just when we come here, we have to hear these stories and say we don't care, but at the same time, every day, all day, we're doing everything we can to change it because this is our people. So I extend that invitation to everyone so we can have a true and honest conversation about the current state at the Pine Ridge Hospital. Thank you.
Thank you. Thank you for that. And, it's just that, we speak for our people. This is everything that we hear every day, and it's been going on for the same year. So it seems repetitive to us, No matter what we try to change, it still comes out with the same complaints over and over and over again for years. And it's not by the same people, it's by new people coming in. And, that's what makes it so hard on us, because that's our job. They put us in this position to fight for them. So, it's nothing about you or you, and it's maybe it's about the system, We know you guys are tribal members, and I don't know if they know your name's Steve up in Eagle Butte yet, but this is just concerns and frustrations that have been brought to us, and it's a burden for us to carry. So we have to come up with good plans and good negotiations that benefit all of our people out there. That's the whole thing about this meeting, is we're here to make sure everything and our people get the best health care there is out there. And I think that's a common goal of everybody here. So thank you.
I'd like to respond. So this is Dr. Jumping Eagle. I guess part of the, when you say you're not seeing changes, I've been pretty transparent in sharing information with HHS and the Tribal Council and sending out the reports, being on the COVID task force on a weekly basis for almost 2 years, if not more. Sometimes we had meetings 3 times a week, assisting the team with writing protocols, all of those things. So I've been actively engaged in working to improve the community's health care. And this comes out of, real concerns that we have a community that has the highest risk medical situation in the nation. And that's what I convey to the medical and nursing providers that come in. Like, this is not business as usual. This is not suburbia. We have patients that have the highest risk in almost the Western Hemisphere. So we have to provide medicine at the highest level of care that we can, and we have to approach the needs of our community that way. I would challenge this governing body of the community to join our efforts and really push any entities that you come across that without the situations that other communities have, like Medicaid for All, we are already hobbled from the get-go. We don't have access to those funds. And that also hobbles the tribe. There's revenue generating activities that could be happening for the tribe regarding the van transport program and other, that could have also helped the ambulance program when it was under the tribe's agency. So, there's opportunities there that your body could be working towards that would help us as a community infrastructure and part of providing the services to the community. We have a really good team at IHS, and to say that when I first walked in there, the average inpatient census was 5. We were only admitting about 5 patients at a time. And now we're up to, at least 15 or 20. Those are patients that don't have to travel all the way to Sioux Falls, to Rapid City, or commute back and forth. We have people that have difficulty with cars, with money. I mean, you all know all this. You get those phone calls. We're trying to provide as many services as we can right there and continue to increase the quality and safety. And as we change the culture at IHS, which is a difficult thing to do, the culture of safety that says, this is our standard, I expect a high level of standard of care. The same when I worked at the University of Colorado, when I worked at St. A's, when I worked at Mid-Dakota, I expect that same standard here at our hospital. It's not different because it's Pine Ridge IHS. I want it to be the best in the region where we can train people and keep people who want to stay. And for us to have the reputation that they want to come here because it's the best place in this part of the country. And that's what our people deserve. And so I challenge you to help us do that. But, that's my mission, and that's our team's mission. I mean, our team has been able to provide over 30,000 COVID vaccinations despite short staffing, and that's through innovative solutions. We've had pharmacy staff providing vaccines. We've had other people trained to assist nurses, even though we're short-staffed with nursing. We've asked for help. The help's not coming. So we continue to do the best we can. The only time we shut down inpatient was because part of our construction project fell through and there was water dripping out of the roof. I called it Sharknado. That was the only time we shut down. But you watch the news and there's other ERs and inpatients that had to close. So I give our team props and all of you working at IHS that you kept the hospital running in the midst of all of these challenges that we continue to face. It's difficult, people are tired. And so I really want to say Wopila to all of our frontline team members who are out there doing the work, and know that you're appreciated. And we want it to be a place where when patients come in, they do feel welcomed. And that's my expectation. So I do encourage you, if you don't feel welcomed or somebody's being rude, please tell us about it. And if I hear about it or one of our team members, we will bring it and we'll follow up on it. And I take that seriously. Thank you.
Thank you, Chair.
Thank you, Councilman. Councilman Poirier, Councilman Dillon, Councilman Steele, Councilman Hawkins.
We took these positions as council representatives, and we more or less put targets on our back. You took them positions, now you have a target on your back. So if we give you a piece of our mind, we don't expect a retaliation from it when we say something. You said in the beginning that you follow tribal laws, resolutions, ordinances, but yet when we pass them, you turn around and question them. If you're a tribal member, then we know that there's federal law, but also you're doing business on the Pine Ridge Indian Reservation, the Oglala Sioux tribe. When that hospital was first built, IHS promised the tribe that there's going to be a service area for the Great Plains, Aberdeen area, whatever you want to call it. Operations, everything was going to happen there. The hospital was built in the 90s. There was a health board at that time made up of one lady from each district, and a lady ran the health board. None of that has ever come true yet. Them women are probably flipping in their graves over the kind of service that we get for our people. and it's quite sad. When we have to send people from our hospital to Rapid City to have their arms set, to have a baby, whatever, that's not quality healthcare to me. Sure, changes are being made administratively, but I beg of Tyler, don't give the names of those people who treated his relative bad in a room, because you could just about guarantee it. There's going to be retaliation against them IHS workers, because that's what happens. We've seen it happen over and over. We was promised things in the beginning of this administration, the past administrations. It's the same old song and dance. Our people are frustrated, and a lot of them go to Gordon to get service. That's not right. That just tells that our system's not working. I got just a couple of questions. How many vacant positions, or if you said it today, do we have on providers, optometrists, and things like that, those that can really provide a service to our people?
We'll look that up. We'll get back to you on that one. We can look that up, I think. What was your second question?
You know, I thought that would be easy to say. You guys are administrators.
Yeah. Oh, okay, here we go.
Is the ER contracted out yet?
So there's a contract, but it's not for the total operations of the ED where it's managed. That it's for providers so that we have the coverage and so that we have nurses and doctors and those folks that are needed to keep it open. Joe, do you want to elaborate?
The administrative portion is IHS run. We do have permanent providers in there, but we also have contract providers.
Is part of them contracted providers the same ones that was ran off here a couple of years ago?
This contract company is not the same contract company, if that's what your question is.
It's the same outfit with a different name?
No.
You're sure of it?
Yes.
Okay. I'd still like to know how many positions that need to be filled of docs, of dentistry, optometry, whatever, in those high positions. How many vacant positions do you have?
25. That's counting some behavioral health staff.
Those are all vacant.
Yes.
So how do you plan on providing a quality service to our people with that short of staff?
So I don't know what you're aware of as far as what the baseline has been, but I mean, the service unit has been operating with a significant number of vacancies for quite a while. The COVID epidemic or pandemic definitely worsened the situation, more so for nursing, and I would say for radiology and lab. But as far as providers, that's been an ongoing issue. We continue, I think we've made improvements with our collaboration with the University of Washington and other recruitment efforts. So we've been able, we haven't seen as significant a shortage as we have had with nursing.
Okay, my last one, if there's an individual that keeps hitting up I and Miss Carlo and probably several other ones, that the child is being referred to Rapid City, And what they're claiming to us is that IHS will not provide the medicine. What's the process of getting that medicine in for that child?
I believe it's a certain type of insulin or something.
So that goes through pharmacy, and then the pharmacy can request special order that.
So that guardian or parent would,
Should follow up with pharmacy.
does it have to come from a doc, or where does it have to come from?
The prescription would come from the provider to the pharmacy, and then the pharmacy would special order the prescription, and then it would come to the pharmacy.
Okay, when you say provider, would the Rapid City provider
The
prescription be, they're not gonna have to come back and say, okay, now you gotta see one of our providers?
We can take outside prescriptions, which is from the outside provider.
That's, here, thank you, that's all I have.
Yep.
Thank you, Councilman, for your, Councilman Dillon?
Thank you. You know, in the past, IHS has not always been honest with this tribe. We sat across from each other, and the truth was not in that meeting at all. And to tell you the truth today, I'm sitting here listening to some of the same issues that we talked about 10 years ago. Things haven't improved in that much time. And it's always been short of staff, short of dollars. We can't get the bills paid for because they didn't report, or they had 72 hours to call it in. They didn't do that. And so it goes on and on and on. And IHS is all that we have on this reservation. And with as many problems that there is, we should take time today and try to fix one of them problems by working together. And maybe we can fix something and then move ahead, because it's like listening to golden oldies here. I've heard this before, and I've heard it before, and I've heard it before. So these problems are now decades old, you know, and there's always, the main problem is the shortage of money. Then all of a sudden there's money everywhere. And so it can't be the money. It's got to be the system that's broke someplace. And we got to find out where it's broke. And that's the only way we're going to fix this, because before you, there was people sitting there telling us the same story. Not all of us, a lot of the people around here have changed, but it's still the same story I've heard for 22 years now. So the change in IHS is slower than a snail's pace, is what I'm going to tell you right now. And so you're going to have to prove me wrong if things have improved, because we're all talking about the same problems again. And I got a report, I got a call here that says an individual was sent a bill for getting a COVID shot in Pine Ridge. Now, if that's true, there's something really broke, because I was told all of those shots were for free. The federal government made them free for everyone. So we need to find that out. And then one of my biggest concerns is that a couple of months ago, we were told there was one IHS, or excuse me, in IHS there was one person in HR. That's why the hiring of everybody was slowed down and broke. I hope that's been fixed, because the way it sounds is we need a lot of people hired at this hospital to get it up and running again. And maybe we should schedule another meeting working at fixing something instead of just having a bitch session, because these get pretty stale and nothing ever accomplished with them. I would like to come away today with something that we fixed, or we're going to fix in the near future, so we can get something done and show the people out there that we can fix stuff up there if we put our minds to it and get it done. Because we've all heard these war stories, and they're true. That's the baddest part about this, is that all of these stories you hear are true. People are getting sent out with the hopes of getting their leg or their arm fixed. They get up there, there's no money. They send you home, and then they bill you. So if you're not going to send them up there and pay for it, then why in the heck do you send them up there? It just don't make sense to me. talk about false hope. And we have a people who's been disappointed so many times, they give up. They live with that limb, they live with that condition until they die with that condition. So, it comes back to, are we gonna fix this, or are we gonna talk it to death again? Because that's all we did is talk about it. We haven't fixed a damn thing today, and we're not going to. We need to sit down across from each other, get everybody out of here, and make some plans on how we're gonna fix it and fix it. And maybe if we do that one time and show that we can work together, we could change this whole system. Because right now, we're operating on a broken system. Thank you.
Thank you, Councilman. Councilman Steele, then Councilman Hopkins.
Thank you, Chairman. I too have numerous complaints from district members that have been treated rudely in our ER when they went, and so a lot of our people are afraid to even go back to get the health care that they need because of their treatment, and a lot of them they don't speak up, and so it's really hard for us to get information on who these individuals are that are treating our people, are mistreating our people. So I just like every other council representative today, we have all these concerns with not only the treatment of our people, but the healthcare we get from IHS. And I was thinking about it. We heard this time and time again. We say there's smoke signals, whatever. But yet we choose not to do anything else but sit here and accept IHS as our healthcare facilities. Myself personally, I would move to go and try to 638 this whole hospital and get better healthcare for our people. But that's just me personally, and I know a lot of people don't understand that the treaty obligation is actually the funding. In the treaties, it don't say IHS is our provider. It don't say that, and it is about the healthcare. And right now we're not receiving adequate healthcare. So I know we're probably all tired of these meetings where we just talk to each other back and forth. We tell you our concerns, our complaints, and you tell us what you want, that you think there is the answer, and I know you're, and I know Dr. Jumpnigo and Mr. Amiot are tribal members, but that don't change the fact that you work for IHS either, and which brings me to and because I don't want to reiterate what everyone else talked about, but this issue that I always bring up in regards to our air ambulance. We have people that need that quick response, but for whatever reason, I don't know what the reasoning is, but you still won't utilize our very own air ambulance when it's crucial moments. You're still utilizing Rapid City, and don't tell me because they're not available. There are a lot of times when they're sitting here and you're not utilizing them, and then that's upsetting. And I don't care about all the Cisco and Eberts that are listening that criticize everything we talk about and all these rumors that I own this helicopter or whatever. I don't care about that. What I do care about is the healthcare of our people. That's the most important thing. And when we need that quick response to get our tribal members out, whatever games are being played at this level to not utilize them is a joke. Whatever those games are, I wish they would go away and you would actually start working with our people. That ambulance service, that air ambulance service belongs to 7 districts of this Oglala Sioux tribe. It don't belong to me. And I could care less what people say out there. That don't belong to me. It belongs to our people. And the purpose of that was to get quicker response, get our people to these facilities that they need to get to in a quicker time, because time is of essence when you're sitting here waiting 55 minutes for a airplane to pull in from Rapid City. So I'm going to continue to bring this up as long as there's these problems still exist. But like I stated, time and time again, we're just sitting here talking back and forth to each other, and nothing will ever change. And it's not us. We're bringing you these complaints, we're bringing you these concerns, but yet they still exist because nothing changes on your side. You could give us all the answers you want, but they're never going to change. So I don't know. I always see these sessions as a waste of time, because nothing will change from today's meeting on to tomorrow, and that's just the way I see it. I had a lot of hopes and support. I supported Dr. Jumpnigo in this position because she is a tribal member, and the reasoning is that I didn't want a non-member to come in to sit in that same position and make decisions for our people. So I really hope things do change, but right now they're not. And I don't need a response back. I don't, because it's just going to be the same thing. I just wanted to I guess grieve and complain, because pretty much that's all we're going to do today, and not get not see any action from it. Thank you.
Thank you, Councilman. Councilman Hopkins.
Thank you, Chair. I guess this for Dr. Jumping Eagle. Heads up. I was asked by my district. They asked what about the OB position in Wambly that was moved to Kyle?
We'll review our positions. Right now, we don't have, if they're talking about a midwife position, there's not a midwife position advertised there. But we do have a nurse practitioner position that will be advertised there shortly at Wambly.
Shortly? How long is that?
Well, it depends. We have a long list for our prioritization list, and that's one of the items I think OST Councilman Dillon was referring to, that there's one classifier at HR, but we've requested help for that person. So.
And we've selected and hired a second one, and we've received some assistance from classifier in another area. So that bottleneck should come to an end here soon. So I would think that position would be advertised,
I would
hopefully
say
by the end of the month.
Yeah, a few weeks.
So in a few weeks, if something happens out to Wambly, then who's responsible for, we're waiting for this, we're waiting for that. Who's responsible if something does happen in the next week, 2 weeks? What excuse are we going to use then?
Right now, we do have, we are in process of making additional selections for all our positions, the service unit midwife positions. We have 2 additional midwife positions we just recently made selections for, and they would be rotating through Wambly as well. They wouldn't be there full time, which I know is what you're asking for, but at least there would be some services available there.
Thank you.
All right, thank you. Councilwoman Whitehorse.
Thank you. Good afternoon. And it was brought to my attention that I can be pretty abrasive, so I'm going to try not to be. But I have a few questions, and I know I've asked several of these before. So I know that IHS received, like, I think it was $8 billion from the ARPA money. how much of that was sent to Great Plains region? And beyond that, how much was sent to the Pine Ridge area service unit?
I don't have a specific number for that. If I could confirm that it was 8 billion, I could very likely tell you that the Great Plains area is like 7.8% of the budget for all of IHS nationwide. So about 8% of that would have come to the area. And then I think around 10%, I'm using very round numbers here, of the area budget is tied to Pine Ridge specifically. But the real numbers I can provide, I don't have them here at my fingertips.
Okay. So I believe that the last year's budget was $6.8 billion. So according to what you just said, we probably got about 10% of that for the Great Plains region.
So the Great Plains area, I think gets 7.8% of the overall IHS budget. These aren't exact numbers. And then I believe Pine Ridge constitutes about 10% of the area.
Okay.
And some different programs use different funding formulas for those calculations. So it's, those aren't numbers that we can budget off of. Those are just me trying to give you a estimate.
Okay. So then my next question, which comes off of that, is if we get about $600 million in our region, then how much of that is kept by the region office and how much of that is sent to our service unit?
Again, I don't have.
You don't have just a general percentage of what would be sent to our area?
So there's lots of different programs and they've taken area shares for this and with the 638. So I don't know, and maybe I should know what that area office budget is specifically, but there's shares that are tied to headquarters in the area, and there's dozens of programs that some tribes have chosen to contract, Title I or Title V, and sometimes they keep the area shares, sometimes they don't. So it's a very complicated calculation you're asking me for the details of. But, a vast majority of our budget goes to direct patient care.
Okay. So then whenever we get our budget and say 30% of that budget is for positions that have never been filled, then what happens to that amount of money?
So if you're talking about, Dr. Jumping Eagle mentioned that there's 34% vacancy rate. Unfortunately, those aren't all fundable positions. We wouldn't be able, with our budget, to fund 100% of the positions that have been created. Not without increasing some third-party revenues, finding other resources to fill that funding gap. So currently, those 34% vacancies, those wouldn't be affordable today.
So that money is just basically non-existent, since there's no money to fill those positions. So that rate shouldn't even be 34%, correct?
Councilman, this is Joe Amiot, and a big portion of that funding that's left over from vacant positions is used for the contractors. So if we can't fill a position, whether it's a nurse, a doc, or whoever, and we have a contractor, then that funds are used for the contractor. And any overruns on, say, the ambulance service, or on, if it's a hard winter and snow removal's extra, or, so that budget's a little bit fluid, and sometimes the funds that are available from vacant positions is used to make up those shortfalls when you're balancing the budget. But I would say a majority of that funding is for contractors.
Okay, then I'm gonna have to go back to what Craig said. We really do need to have a sit down, and we need real numbers, and we need to have a real plan. Because at the last council meeting, when Dr. Jumpanigo made her report, we were told that we were, I think it was 32% at that time vacancy rate. And then Mr. Dillon asked her at that time what happens to the funding if those positions are not filled. And we were told at that time that the funding for those positions remain within the service unit. But if there's no actual funding to fill those positions, then that funding doesn't remain within the service unit. Am I wrong?
Yeah, that's not correct. All the funds for Pine Ridge stay in Pine Ridge and are used for the services in Pine Ridge.
But what we were just told was that several of those positions are not even funded. So we're talking about money that doesn't even exist, right?
If all of those positions were funded, if we were 100% filled, then we would have to balance the budget as we do every year as a federal program, and if we don't, we're in violation of the Anti-Deficiency Act. And so if every one of those positions were filled, everyone on the books, we would have to increase third-party revenue to ensure they are all covered and our budget stays in the black.
But as it stands right now, those positions are really, maybe they're needed, but there's no funding to fill them. So there's actually no dollars that we're talking about that stays within any area because there's no dollars. Right?
Yeah, I think I hear what you're saying. So there might not be funding associated with that specific position. The position might be mothballed, where there's no intent to fill it because there's other priorities or something. So I wouldn't go on the number of positions as an indicator of the health of the financial health of the facility. There's other ways, and I really do like the idea, Councilman Dillon, and your idea of having a working session, and we could go through these numbers and we can go through some specifics and the ways that we measure the health of a facility. We have our IHS internal controls that we have to follow to ensure we're in compliance with coding and billing and budget and revenue. So it's a whole world that we would sure welcome a visit to go over these details and have a working session. And so we can show you the health of the facility or the improvements of the facility. And then you bring your concerns from your constituents and from your own experiences, and we work to resolve those with a real plan, and I think that's an excellent idea to move forward.
Okay, then I guess my next question, and I really do think that does need to happen sooner rather than later. I sit on the budget formulation committee for IHS, as well as Chairman Herman and Miss Colomb out of OHC. And I don't agree with that process at all, because it feels like it's just coming directed from IHS. It's not the needs of the tribe. It's the needs of IHS, and they're just using us to lobby for them. That's what I see. And I think that there needs to be a better process for that. I'm not an expert on it, so I don't know what the process would be, but I think that there needs to be more tribal involvement. And I think that one of the biggest needs on our reservation is I guess health insurance, because you know it gets really old when everybody is referred out from IHS because they can't provide the services that people need. They don't have a specialty doctor for liver disease, and cirrhosis is a big thing. They don't have a specialty doctor for a nephrologist unless you get there at exactly the right time, or you get sick at exactly the right time. Otherwise, you're referred to Rapid City or Rosebud. And I think that, and then other things like rheumatology. If you have rheumatoid arthritis, you're going to have to go to Sioux Falls or Rapid City. I think that we need to provide better services for people with critical conditions. There has to be some way to take care of our people better. And I don't know how many times I can say it, but I'll probably keep saying it until it actually happens. But we need to do better. Our people are sick and dying, and we can't do anything about it. We have so many behavior management and addiction issues on the reservation. Well, everywhere really, but on the reservation, it's pretty much a pandemic. I mean, at least weekly, there's a suicide, sometimes more. And we don't have the resources to help people. We don't have a psychiatrist who may be able to provide treatment. We don't have enough behavior management people to listen. We don't have a way to stop this from happening. And we have our people who are sick and so worried about healthcare and getting bills for healthcare that should be provided by IHS. And what can we do except to tell them, well, don't worry, because Sarah said, just give me your bill and I'll take it to Sarah. And then a month later, they're saying, oh, I still got the same bill. I don't think I should go see the specialist anymore because they're charging me $25,000. IHS is supposed to be taking care of it, but they're not. And the thing with the pharmacy, you know, I had 3 people in my district who required 2 required specialty medicine. 1 required a cream for some nerve damage that was caused at IHS ER. And IHS would not pay for the cream. And it was $289 for a little 4-ounce tube. She was lucky because her mother paid for it. But not everybody is that lucky. And you know, the way I see things, if there's one person who comes to me with a terrible experience for IHS, there's at least 5 other people who are not going to come to me and tell me what happened. And beyond that, there's probably 10 more people for each of those 5 others who will not tell anybody what happened. And I'm very vocal, so I bring my issues up to Dr. Jumping Eagle. I bring my issues up to my primary care provider, who's very good, by the way. She's on the ball all the time. But not everybody will. And those are the people that we need to speak up for. And those are the people who usually need more care. You know, our dental programs are just ridiculous on the reservation. We had a district member here with heart trouble, rotting teeth, whose appointments were canceled by IHS twice. And his heart surgery was canceled because he could not get his teeth fixed. And his doctor told him that would affect his heart. So I sent an email on that to Sarah. And you cannot, the only thing that IHS is doing in their dental program is pulling teeth. They're not doing cleaning. They're not doing checkups. They're not doing any type of repairs. My daughter had a root canal. A root canal. All you have to do after you have a root canal is put the filling in. And she was told at Pine Ridge that they could drill her tooth, take the nerve out, and that's it. They could not fill her tooth. And the dentist in Pine Ridge told her, Dr. Jumping Eagle said we cannot do any procedures. So I don't know if that was an exaggeration on her part or what. But there has to be something done. We have to do something better. And I think a working session needs to happen as soon as possible. Because our people are sick and dying. And I could understand when they think nobody cares because nothing is being done, or that's the appearance. There just needs to be something done. We just need to do better. Thank you.
This is Dr. Jumping Eagle. So regarding dental care, just this month, our dental team, we had ordered equipment quite a while ago, and our dental team is providing root canals. So I don't know when that specific patient had that experience.
It was last week.
Okay.
She had a root canal and they never filled it. So
okay.
It's an empty tooth. But I took her to Winnebago and they
So we
fixed
could
it.
follow up on that because, you know, Dr. Dimmitt's the dental chief, and I believe she actually came from Winnebago, so she's well versed in dental procedures and in root canals. And that's been one of our goals for the dental team to start implementing that. So I'll follow up with her about that. Regarding the coordination of care issue, I know that at times it is frustrating if some of our staff are out ill and we have to reschedule patients, but we do try hard and did assist a certain patient with coordination of care. There are certain creams that if there are controlled substances involved that we can't compound them within our pharmacy or special order them. So there are certain restrictions that our pharmacy has for our federal agency, and we have to follow those policy. I know those are frustrations or challenges. We try to be as flexible as we can. If we don't have something, that we try to order it for patients. But there are certain situations where we just can't work around some policies. Otherwise, I would just say in general that, you know, I appreciate the feedback, and that we do, you know, when I do receive information about concerns, that I do work to follow up on those concerns in a timely manner.
Just FYI, I just got about 5 pictures of people's root canals that are just hollow teeth. I could forward them to you if you want.
No, I can follow up with Dr. Dimmitt, the dental chief, and then follow up with you. I can't speak to
2 of
the
them were from
root canal
Wombly.
process, but my understanding of the root canal process is a several stage process.
It's actually not. I've had one, and my daughter had one, and they just, at Winnebago, they take you in the morning, they take out the nerve, they fill the tooth, and you're done. It can all happen within an hour and a half.
I don't know what the differences are, but when I've had root canals, there's several stage process. So I'll follow up with Dr. Dimmitt though, and follow up with the concerns.
Does Dr. Demmett also supervise Wombly Health Clinic or their dental program?
Yes.
Okay.
Hi, this is Joe. I would like to have that information on those patients that sent you pictures of. If you could send that to me, I would really like to follow up on each one of those.
Okay. Do I have your email?
It's joe.amia@ihs.gov.
Okay, I'll send it.
Okay, thank you. Is there anyone else? Okay. So I think I guess I'll just let Dr. jump in. You'll have a closing statement, but before we do that, I think you heard from 16 of our council members, and since almost 11 o'clock. And basically, I know there's things that need to be fixed, and I don't know if you want to address some of that or what you heard and all that, but also the idea of a working session. I know that's come up, and definitely if it is up to the council, I'm sure that we'll have to work on dates and try to figure out what that might look like. And definitely just trying to, this is more than a work in progress, honestly, but based on what was heard, and definitely just want to make sure that you guys have a closing remark. So
I'll be brief. Thank you again for coming. I guess I was anticipating some shared frustration. We do have a passion for improving healthcare. We do want to be great teammates and partners. I've got lots of notes. I very much support more working sessions. I support participation in the work groups that IHS tries to do nationally. I support the tribal participation in our governing body meetings that we have quarterly. The next one should actually be on site at the hospital if COVID allows. So I encourage as much participation as possible with that. Then we really do have the real numbers that you can take a look at and see trends and see some of that progress that we feel. And we're just waiting for it to catch up and hope that you feel it as well. But thank you very much for the invitation today. I look forward to our next meeting.
Thank you, and thank you to the OST Council, to the OST leadership, and to the community members that are listening. And again, I ask that you welcome feedback for our hospital and the services that you receive at the Pine Ridge Service Unit. At the service unit, we're working hard to improve the quality and the safety of care. If you have concerns about or suggestions for improvement, we always appreciate that. I think for you as the community members, if you have ideas on ways that we can improve, whether that's, like the check-in process or the door screening. We've gotten a lot of feedback about the emergency department, and we've implemented changes within the emergency department. We're continuing to encourage improvements within customer service. We really see that we're there to serve the needs of the community. This isn't just a job. This is Something that for me as a Lakota woman, growing up seeing that my grandmother was Juanita White Eyes. I grew up seeing her working in the community as a nurse for 30 years. My uncle is John White Eyes. He worked with they helped develop the ambulance program. We had people knock on our doors in the middle of the night and ask for help. So that's always been a part of what I wanted to do when I grew up, was to come back and help the community. So yes, I hear you, Uncle Dave, that I do have a target on me, and I've been, someone asked me if I had shoes with tread on them so I could run away. But I'm one of those people that's gonna run towards you. And I'm gonna run towards assisting the community, and that's who I am, that's the family that I come from. So I thank you for this opportunity to serve you as the community, and I will continue to be here for the community. Wopila.
Thank you again, appreciate your participation today. Thank you for setting up time. We'll be in touch with dates. I think our secretary will follow up and see what would work for a working session. So council, I guess at this time we can take a break for 10 minutes, and then we'll come back. I think we have 2 more issues, and then after that we'll be done for the day. Thank you.